Okay, so we have the clinical significance of your osmometry. So basically that one could eventually help here to evaluate for the kidney's ability to reabsorb or to concentrate. Second one, to monitor the course of the renal disease. Third one, monitor here fluid and electrolyte imbalance. And the fourth one is for the differential diagnosis of your diabetes insipidus. Diabetes insipidus is a medical condition characterized by the absence of your antidiuretic hormone. Remember that your antidiuretic hormone is the one responsible here for the reabsorption of the water in your collecting ducts. Okay, then we have here the normal values for your osmolarity. For the serum, that's 275 to 300 milliosmol. For the urine, that's 50 to 1,400 milliosmol. But usually, this become here diagnostic if you try to take this one as the ratio of your serum to urine osmolarity. And the ratio should be 1:1 to maintain here the osmotic gradient. Okay, again, we could use this value here basically to differentiate the different causes of your diabetes insipidus. Again, there are two types or mechanism here why you have defective reabsorption of the water in the collecting ducts related to your diabetes insipidus. One, we have here the neurogenic. Remember that your antidiuretic hormone is being produced by your hypothalamus. So basically, if you have problem with your hypothalamus, so expect here that it will not produce antidiuretic hormone. If the problem is on the hypothalamus production of your antidiuretic hormone, then you consider the diabetes insipidus as neurogenic DI. Pag nephrogenic DI naman, okay, what you have here, pag nephrogenic, you have a normal production of the ADH with your hypothalamus. Only that, your ADH do not bind to its receptor in the collecting ducts. Okay, pag hindi siya makapag-bind sa receptor sa collecting ducts, what we are expecting, again, it will not also reabsorb the water. So both of that would result here for deficiency in the reabsorption of the water because you have a defective ADH. So nephrogenic and we have also your neurogenic. Okay, then we have here the test for us then to differentiate if the condition of the patient is nephrogenic or neurogenic. So you just need to challenge the patient by giving antidiuretic hormone, and then you try to give also here a fluid control diet. So basically, if the result, for example, the baseline before challenge, okay, before challenge here, you try to measure the serum, urine, osmolarity of the patient. If before the challenge here, the serum, urine, osmolarity of the patient is 1:1, then after that one, you try to challenge the patient by giving ADH and a high fluid control diet. And after the challenge here, the serum urine osmolarity of the patient try to increase to 3:1. So that's your neurogenic. Bakit neurogenic? Okay, remember here ang ginawa mo dito, nagbigay ka ng ADH. Ano ulit ang problem sa neurogenic? In the neurogenic, the problem is your hypothalamus, diba? Wala kang ADH is because here your hypothalamus is really defective in production of your ADH. Kaso nga lang, in this procedure, nagbigay ka ng ADH. Okay, since tumaas siya, mean to say, ang problem ni patient is on the hypothalamus. So, pag nag-increase siya from 1:1, after challenge, maging 3:1, that's your neurogenic. On the other hand, pag ito result, baseline, before the challenge, okay, the serum urine osmolarity is 1:1, but after the challenge, after giving ADH, after giving here the fluid control diet, walang reabsorption na nangyari. 1:1 pa din. The problem here is the nephrogenic DI. Paano naging nephrogenic DI? Remember, in the nephrogenic DI, you have a normal EDH production. Kaso nga lang, hindi siya nagre-reabsorb mean to say hindi siya functional is because hindi siya nag-respond o hindi siya nagbabind sa kanyang receptor sa collecting ducts. You have ADH pero hindi siya nagpa-function. That's your nephrogenic. Kaya before challenge and after challenge, ganun pa din siya, walang reabsorption ng water. That's your neurogenic. Dito naman kasi sa nephrogenic, ang problem mo ay wala ka talagang ADH. But since you give ADH in your procedure as your challenge, pag nabigay ka ng ADH, nagkaroon ng reabsorption, okay, that would increase your serum urine osmolarity to 3:1 after challenge. Then we are diagnosing the patient to have a nephrogenic diabetes insipidus. Okay, the next one, we have here the free water clearance. The free water clearance is the expansion of your standard clearance test. This would eventually identify here if your body is excreting much water or less water your body is needing. So notice here, this one is just, ito yung formula natin ng standard clearance natin, diba? So U times V over P. Only that this one is osmolarity. Whatever the result for this one, just need to minus with the total volume ng urine output. So, whatever the result here, ma-minus mo sa total urine output, into say measure mo yung total urine output ni patient. So, for the interpretation, if after, i-minus mo dito sa total urine output volume ni patient, if the result's negative, ano ibig sabihin ng negative? Kulang ang nire-release or in-excrete na ihi ni patient. Okay, sa kanyang kailangan na tubig sa katawan niya. Mean to say the patient is dehydrated. Pag ang result mo dito ay positive, mean to say this one is positive or mean this one is more than. So, mean to say sobra sa kanyang water ay ni-excrete niya more than sa what is being needed by the body. So, mean to say the patient is adequately hydrated. Pag zero, that would signifies walang concentration or walang dilution na nangyari dito. Again, those are the tests for evaluation of your tubular reabsorption. Again, other name for that is your concentration test. Okay, the next one, we have here the test for your tubular secretion. And we have also here the renal blood flow. They come together, your renal blood flow and your tubular secretions. It's because here that in order for you to have an effective na tubular secretion, you should have an effective na renal blood flow. Tama ba? Saan ulit nangyayari ang tubular secretion natin? Dito sa peritubular capillaries. So, para magkaroon ng tubular secretion, dapat ang blood natin effective, ang flow niya papunta din dito. Kasi pag hindi siya effective, hindi siya makapunta dito, hindi mangyayari ang tubular secretion. That's why your tubular secretion and renal blood flow here should go hand in hand with one another. You should have an adequate renal blood flow in order for you to have an adequate tubular secretion process. Okay, the test for evaluation of your tubular secretion is also being called here the clearance test. The clearance test, katulad kanina sa ating glomerular filtration, because again, this would measure the capacity of your renal tubules to secrete or to remove substance in your blood dito sa peritubular capillaries papunta dito sa renal tubules for eventual excretion. Only that pinagkaiba, ang nangyayari, ang removal ng substance or clearance ng substance occurring in the peritubular capillaries, not in the glomerulus. Kasi pag dito sa glomerulus nangyari, so glomerular filtration rate yun, hindi siya tubular secretion. Okay, the substance used for evaluation of your tubular secretion, we have here your PA or your para-aminohippuric acid. Para-aminohippuric acid is an exogenous substance. Mean to say you need to infuse that one to your patients. Your PA, bakit siya ginamit as your test for glomerular filtration, test for your tubular secretion? Because again, this one is not filtered by the glomerulus, but rather being secreted in your peritubular capillaries going to your proximal convoluted tubules. This one is not filtered by glomerulus because again, this one is loosely bound to your proteins. Remember that lahat na protein-bound substance, they are not filtered by the glomerulus. But then, upon contact with your peritubular capillaries, again, this one would have a strong affinity for your protein-bound substance, and therefore dito, masi-secrete ang ating para-aminohippuric acid papunta dito sa renal tubules for eventual secretions. For your PA clearance, since this was also a clearance test, only that magkaiba lang sa, again, hindi siya nangyari sa ating glomerulus. Ganun pa rin ang ating formula, the standard clearance formula. We have urine PA concentration in mg per dl multiply with the volume of the urine output. Then over here, the plasma para-aminohippuric acid level or concentration. Okay, the normal values here, 600 to 700 ml per minute. Again, your 600 to 700 ml per minute, this is your total plasma flow, not your 1,200 ml per minute because again, bakit hindi 1,200 ml per minute? Because again, 1,200 ml per minute pumapasok dito na blood, di ba? Nagkakaming contact lang dito sa peritubular capillaries natin, so only 600 to 700 ml per minute. That's why, yun, doon nakabase ang normal values ng ating para-aminohippuric acid because not all your total volume of your blood come in contact with this area. Kasi ang iba ay dito pumunta. Therefore, try to adapt here the normal values of your total plasma flow. Okay, then we have your titratable acidity. So, basically, every day, we are excreting approximately 70 MAQ per day of an acid. So, nililabas natin na acid sa katawan natin 70 MAQ per day in the form of what? So, itong mga acid natin, titratable acidity, your hydrogen ion concentration, your dihydrogen phosphate, tama ba? Dihydrogen phosphate, and your ammonium ions. That's what we have discussed kanina with our discussion with your tubular secretions. Okay, so basically, we tend to have your high pH or alkaline pH here during this time. After meal, these are alkaline tide, and usually between 2 to 8 p.m. Okay, so again, every day we are supposed to excrete an acid at a concentration of 70 MEQ per day. So to measure here the ability of the patient to excrete an acid, then you need to challenge the patient. Kaya niya ba mag-excrete ng acid? So bibigyan mo siya ng acid and then try to measure kung kaya niya ma-remove ang acid na binigay mo. Try to challenge the patient by giving an acid in the form of your ammonium chloride. And after that one, try to measure the following concentration as a reflection of your acid excretion. So the first one, we have total acidity. We have also here titratable acidity, and we have your ammonia concentration. But the available test method lang, the laboratory, is we tend to measure only the concentration of this one, total acidity, saka titratable acidity. What we are doing to identify, determine the concentration of your ammonia is just only to derive the concentration of this. All you need to have here are the values of your total acidity. Ima-minus mo ang value ng titratable acidity. Ang remaining nyo that become here the ammonia concentration. Then we have here the condition, renal tubular acidosis, or you call it once your metabolic acidosis. This is a condition in which the patient could not excrete an acid. Okay, so hindi niya kaya ma-excrete ang acid, that's why, di ba, challenge natin para malaman kung kaya niya o hindi. Kung hindi niya kaya, that's why may mga normal values din mga ito. Kung hindi niya kaya excrete, it may fall here in a condition called the renal tubular acidosis or metabolic acidosis. Okay, so again, it's inability of the patient to excrete an acid urine. So therefore, we are expecting na ang kanyang urine is an alkaline na urine kasi hindi niya na kaya mag-excrete ng acid sa kanyang katawan. Okay, so that's all about the renal function test with a different test for the evaluation of your three renal functions, GFR, glomerular filtration rate, tubular reabsorption, and we have your tubular secretion. Okay, thank you for this video.